Through this, you guys can go eat. Yep, it's the last one. All right, ACS, acute coronary syndrome. Does anybody know the 3 forms of ACS? STEMI, non-STEMI, and unstable angina. Or angina, however you want to say it. All right, good. You guys know the structures or the structure of arteries. We don't need to go through this too much. But when we're talking about acute coronary syndrome, it's important to obviously know how the occlusions happen, how you get the atherosclerosis and the plaque buildup and the clogged vessels, right? So that outer layer is the tunica adventitia. That's all your connective tissue. Then your inner layer, that's where your middle layer, that's where your smooth muscle is. And then your tunica intima is your endothelium, and that's where you get passage of cells, usually white cells, different kinds of white cells can get through the endothelium to get to infections of tissue elsewhere. But that migration is when cells go through the endothelium, that's what it's called, is migration. That migration is important in atherosclerosis. We'll find out. So that middle layer is the smooth muscle. This is where your nerve fibers are, your autonomic nervous system. Obviously, that's what's controlling constriction and dilation, right? And then your intima, where your endothelium is, that's where your migration is, that's contact with the bloodstream. All right, so this gives you kind of an example. So this is going from normal vessel to progression of a diseased vessel, right? So this is what atherosclerotic vessel will look like. This is what a normal vessel looks like. You get migration of white cells that come in here, macrophages, and they eat up a lot of the lipids to try to get rid of them. When there's too much, oftentimes they don't just stay there. So you get this excessive adipose tissue and macrophages and white cells that can scar in and create a plaque. All right. Let's see. So pathology here, you go from that normal artery. When you get lesions or whatever kind of dysfunction caused by disease, diet, whatever, you get this fatty plaque that begins to form, and that's underneath the endothelium, right? When you get an advanced vulnerable plaque is when it's large and it also has its own blood supply. And vulnerable plaque is one that can rupture, bleed, break, okay, go from stable to unstable. So when you get a plaque buildup here, you decrease flow, and you can get an aneurysm of the vessel itself. That could certainly burst, and then you can bleed out from an aneurysm, and then the blood flow is not going to the heart, it's going into the pericardial sac or whatever. And then you can get, if you get bleeding inside the plaque, and you can get a thrombus, and so it clots in the leftover space that you have, or you can get just critical stenosis where it gets so big it cuts off too much blood supply. You get worsening angina until the patient just doesn't have enough blood supply. Or if they're doing something where they require more demand, but they don't have the flow to get it there because the plaque buildup is too big. That's why, you know, people drop dead exercising or mowing their lawn or you know, whatever. So this is just a kind of a view of atherosclerosis in the aorta. A is kind of mild atherosclerosis, where it's mostly fibrous plaques, but you don't have a whole lot of, you know, bleeding in there. Severe disease, you've got all these pockets of clots and bleeding, and B is where you have very vulnerable plaques, okay, that can rupture and bleed and whatnot. So this is a comparison of your stable and unstable. So stable plaque, you've got your lipid core, and you have your lumen, but it's not prone to you know, that bleeding. But when you've got your lipid core that's kind of surrounding your lumen, then that becomes vulnerable because you can have bleeding that then goes into the lumen, clots off, and then starts to block the lumen. It seems a little against your intuition because you know, just looking at the pictures, you think that the one up above would be worse because it seems like the lumen's smaller. But it all depends on how stable that plaque is and where it's at. If it's more concentric, then it's more vulnerable. If it's surrounding the lumen. Does that make sense? So this is an example of just a plaque rupture. You have bleeding inside your plaque buildup, and then that bleeding gets so bad that it actually ruptures out into the lumen. And when that happens, it creates a coagulation cascade, right? You get platelets, fibrin starts to form, and you get a clot. And that's when you get these sudden onset heart attacks. So this kind of goes through the physiology of the plaque rupture and how fibrin is formed. So platelets are going to be attracted to these areas of injury, right? But the platelets aren't going to form a significant clot until there's fibrin involved, right? So you get this cascade where you got prothrombin to thrombin, then the thrombin acts as a catalyst to turn fibrinogen into fibrin. And when that fibrin is formed, that's when those platelets really start to bind together and you have a clot. So your anticoagulants oftentimes work on this. Like a lot of heart patients, you know, are on aspirin. What does aspirin do? Say what? Okay. So they are COX-1 and 2 inhibitors, both aspirin and what am I thinking? Plavix. No. Yes, Plavix. Plavix is kind of a cousin of aspirin. They are COX inhibitors, so they inhibit this, well, part of the cascade. So fibrinolysis, and this, your guys' drug profile for this week, includes the main fibrinolytic. And what do you think that is? Alteplase. What is the common name for alteplase? TPA. TPA is the clot buster, right? So it activates the breakdown of these clots. And you get the breakdown of the clots when you have plasmin. Plasmin is stored as plasminogen, but it's not activated until there's a certain process, and that's what alteplase does, is it activates that process, so you get plasmin, and it actively breaks down the clots. But it's super fast acting, and it's gone almost as quickly as you give it.
What's the difference in process between TPA and TXA?
Tranexamic acid? Tranexamic acid, we don't actually know what the chemical process of tranexamic acid is and why it does what it does, but empirically we have so much evidence of its effectiveness that it's used mostly in trauma settings.
It causes clots.
You guys don't have tranexamic acid.
We don't, but there's talk about getting it. So.
Yeah, it makes sense. There's not a whole lot of downside to it, and it's certainly effective. They do the exact opposite, but what?
Just real quick, going back to acid and flavoring, there's something very interesting in an article in the Journal of Medicine about rivaroxaban. That's something that you see much in the ER.
Yeah, we see rivaroxaban. Rivaroxaban is a cousin to apixaban. So these are all the new oral anticoagulants. You know, your Xarelto, your Eliquis. Apixaban is Eliquis. And there's also dabigatran. These are all the newer oral anticoagulants. They work on different aspects of the coagulation cascade. Usually, or at least a lot of them, work at cofactor 10. You see those very commonly because they're a lot easier to take than warfarin. So more and more patients are on those medications than on warfarin. You don't have to get your blood tested. It has a very quick onset and offset. So if you stop taking it for a day, I mean, that's can be a plus and minus. It's a plus from the hospital perspective because we don't have to worry about it for very long. But if you stop taking it for a day, it's not effective anymore. But in the opposite, you know, it takes a week for you to get your Coumadin levels up to speed, whereas with these new oral anticoagulants, you take it and within 6 hours your concentration is good. So
in conjunction with aspirin, that they can put the patient at a higher risk for bleeds.
Yeah.
With them just aspirin alone.
Yeah, absolutely. Now, if they're taking a baby aspirin, there's not a whole lot of increased risk, but there still is a little bit. All right, so your complete occlusions, those are your STEMIs and sudden deaths, right? Incomplete occlusions, those are your silent heart attacks, unstable angina, and STEMI. They can also cause sudden death. What is an unstable angina?
Not getting anything you're arrested.
So, yeah, it's a change in angina, right? So an angina is a predictable phenomenon, or I shouldn't say phenomenon, but a predictable symptom where you know that if you work this hard, you're going to start to get chest pain. If you increase the demand on your heart this much, you're going to get chest pain because you have atherosclerosis, your lumens are smaller, and if you do anything to put your heart at has to work a little bit harder, you're going to get certain symptoms: shortness of breath, chest pain, weakness, dizziness, nausea, vomiting, lightheadedness, syncope, whatever. Unstable angina is when those same symptoms happen either accelerated, meaning over the last, I used to be able to walk a mile, and now, you know, over the last week, I'm down to like 50 feet. That's unstable angina. There might be a fairly quick, accelerated process. It might be just that now you're having symptoms at rest. That's unstable angina. That means you're just sitting on a time bomb. And with unstable angina, you don't have necessarily EKG changes. It's historical, but it still means the same thing. They still need to be capped. It's still dangerous. If something isn't done, they are going to have a heart attack.
You get EKG changes with stable
You do if you do it during exercise. That's what a treadmill is for, right? Yeah, different kinds of stress tests. You can do medically stress them. You can do treadmill stress test, but that's what it's for, is to put them in a demand situation and then get an EKG and see if there's changes, see if they have symptoms, and also, depending on what kind of stress test it is, you can actually look at the heart tissue and heart muscle. Because we have echo stress tests too, where we do an ultrasound and take a look. So, factors affecting outcome. Obviously, this all comes down to the amount of myocardium affected and how much is supplied by the artery that sucks, right? Depending on if you've got pacemaker cells in the vicinity, that obviously, even if it's not a terrible amount of area that's affected, if it affects your electrical conduction system, that can be a big problem, right? If you already don't have enough blood flow and then you take out your AV node and you rely on your Purkinje system beating at 40, well, now you really don't have enough blood flow, and then that injury just gets worse and worse. They go from lightheadedness to dead. So angina pectoris is chest pain caused by dead heart tissue or dying heart tissue. Patients describe this in a lot of different ways. As you guys know, sometimes not always clear or classic. Sometimes patients get really creative in how they define their symptoms. So, common sites. Most of the time you get that central chest pain, chest burning, right? Oftentimes you'll get radiations into the neck. Classic, I think, would probably be C, where you get that chest pain and then radiations down into the left arm. The crappy ones are the ones where they only have epigastric burning, and it feels just like their GERD. Oh yeah, I have GERD all the time, and this feels just like it. Those ones are the ones that people miss, and miss often. Back pain can sometimes be tough. So people always want to equate it to something they did, even if that really wasn't the cause. All right, stable angina, we talked about that. This is constant and predictable. All right, severity is obviously how much they can do without getting symptoms. And then what their response to therapy. That's why a lot of these patients, they're prescribed nitroglycerin, and they have nitroglycerin with them all the time. If they have this chest pain, then they take the nitro. So I guess the next question to that is if the cardiologist knows that they have angina, why wouldn't he just go in and fix the atherosclerosis? What do you guys think? Okay, that is certainly true. That lifestyle changes really is the lifestyle changes really are the answer, or answers. If you don't change your lifestyle, then it's just gonna get bad eventually anyway.
Particular accessory arteries a chance to move it?
Okay, over time you'll get accessory circulation pathways. That's true as well. It's a risk-benefit ratio, right? There's risks to going in and doing a surgical procedure, and there's statistics on all of those kind of procedures. You know, doing a cath, putting a needle into the vulnerable arteries of your heart, obviously is dangerous. You can puncture, you can cause aneurysms, you can break off plaque and then cause a thrombus and then cause a heart attack. You know, it's a risk-benefit ratio. So unless that artery gets occluded above general rule 80%, some cardiologists don't do it until it's 90% occluded, and they don't open them up.
So the lifestyle changes, if they've got that plaque built up in there, they start taking care of their heart and watch their cholesterol and whatnot, does it eventually go away?
I mean, you are still going to have damage to the vessels, so you're still going to have scar tissue and that stuff that won't go away, but the plaque will resolve over time. Yeah. Because your body starts to get rid of all that adipose tissue, right? And it gets rid of adipose tissue everywhere. So that's a big misnomer with exercise in general, right? If I exercise my abs and do crunches like crazy, it's gonna get rid of the fat that I have around my midsection. That's absolutely untrue, right? So your body will dispose of fat everywhere at the same time. So eventually it'll do it, but there's no such thing as spot weight loss. So all those, you know, sweatbands and stuff, that's just all. It might look better for an hour after you take the sweatband off because that skin is dehydrated, but once it gets filled back up with water, then it's the same. But there's no such thing as spot weight loss. So yeah, it will take a lot of time because your body's gonna start to burn off and use glycogen stores and adipose tissue from all over the place. And your heart might not get that attention until further down the road. All right. Let's see. So with stable angina, sometimes it can be tough, right? People just get nauseated. I got this burning in my stomach and I feel a little nauseous. Well, that's a million different causes. But right. So, but what is the harm of getting an EKG, right? Super quick and easy. If the patient has risk factors and anything close to the heart with symptoms, might as well get an EKG, right? Even if they think that there's a direct cause and direct correlation, why not get it? So unstable angina. So you have one or more of the following. Usually lasts longer than 20 minutes. So generally, with stable angina, you feel the symptoms, either take nitro, it goes away, or you rest and it goes away. It doesn't last very long. Unstable angina lasts longer. The symptoms are more severe, new onset, or you're getting an accelerated rate of these symptoms with less and less exertion. Prinzmetal angina. This is when your coronary arteries spasm. So who does this happen to? Could happen to anybody, right? People's muscles spasm. It's kind of bad luck to have that muscle spasm happen in your heart, but it certainly can happen. Or at least I should say the blood vessels in your heart.
Would that be more common in somebody that's got like a seizure disorder or Parkinson's?
No. It becomes more common as people age. And the sicker somebody is, the more coronary artery disease they have, the more likelihood that they could have Prinzmetal angina because those arteries are already have dysfunction. So they're more prone to spasm. but anybody could spasm. So it can be precipitated by a number of things, stress. So you got that anxious girl that always calls because she's anxious. Now she's having chest pain. Well, yeah, she could be having princemental angina caused by her own anxiety. Exposure to cold. It usually happens at rest. Oftentimes, it'll wake people up from sleep. And it can happen in clusters. Relaxes, spasms again, relaxes. It usually is relieved by nitro. You guys can imagine why, right? What does nitro do? Vasodilation. Good. So relieves the spasm.
Smooth muscle relaxing type thing.
That won't work on. Now, when you say smooth muscle relaxant,
Get you the different
no, that won't really work for Prince Metal, and the onset of those medications would be way too late, so it wouldn't be effective. So I mean, your Prince Metal angina, your symptoms would be over before the medication ever started to work anyway. But in general, the heart's smooth muscle tissue works a little bit differently as well. But yeah, you can have ST segment changes during this because you don't have enough blood supply when it's spasming down, right? So myocardial injury, this is reduction of blood flow, reduction of oxygen to the area. So ischemia is different than infarct, right? Ischemia is dying or will die. Infarct is dead tissue. All right. So we've talked about this a little bit. That this just quickly goes over the coronary arteries again and the surface areas that they cover. You see how that RCA wraps around and does most of the posterior? Circumflex wraps around that kind of lateral left ventricle, but doesn't do as much posterior. So MIs, subendocardial is that more inner layer. Which part of your layer gets hit first? So we got endo and epi votes. How many people say endocardium gets hit first? Meaning first to die. Endocardium. How many people think epicardium is the first to die? So the first to die would be the most distal from the blood supply. So it's endo. So endocardium gets hit first. Transmural infarction is when you've got infarct through the whole layer. All right, so the endocardium has been hit, and you've got infarct through the whole layer. Very rarely would you get a localized epicardial infarction or subepicardial infarction. Just depending on what kind of weird blood supply you've got going on, you could certainly still have it. Intramural is, yeah, when you've got injury kind of right in the middle. Sometimes it just depends on how the branches are, and if the occlusion is more distal and it's only occluding that branch that's going towards the middle, then you can still have infarct in those areas. It's just more rare. So this just gives you kind of a timeline, or I guess percentage, for ischemia, injury, and infarct as you're going through. So however long that blood supply or that lack of blood supply is lasting, you're killing more cells, right? So there's a trigger for about half of patients, which is kind of a scary thought because that means in half of patients there's no trigger. It just happens, right? Chest discomfort or chest pain is there in most patients, 75 to 80%. Of course, not all chest pain is heart attack. I would say a grand majority is not. But just because they're not having a heart attack doesn't mean that their chest pain isn't ACS related, right? They might not be having heart muscle infarcting or ischemic, I should say, infarcting, but it could be still a cause of lack of blood flow to that area. It's just not heart attack, it's not infarcting. Okay, anginal equivalents, meaning things that would be the same as the patient having anginal symptoms, but not necessarily chest pain. So generalized weakness. Some people would be like, oh, I just have been feeling super tired for the last couple of days, and I have no idea why. Difficulty breathing, excessive sweating, that's the diaphoresis question, right? Nausea, vomiting, dizziness, syncope, near syncope, palpitations can be anginal equivalents. So a new onset dysrhythmia can certainly be because of ACS, right? Just feeling tired. Atypical just means that it's not classic, right? They don't have the typical chest pain. They have these atypical symptoms. They have symptoms that seem like they would be something else. Rib pain or lung pain or acid reflux or whatever. You've got all these different atypical presentations. Older patients will oftentimes have atypical symptoms. Diabetics will often have atypical symptoms. And women will often have atypical symptoms. Questions about ACS? Angina, unstable angina, NSTEMI, STEMI. Nothing? Good. Go to lunch. Be back at 12:45-ish.